for the femur, for the pelvis, for the bilateral frog legs. The only thing that will not be on the 14 by 17 will be the unilateral hips. Okay, so anything that's a single hip, we can do on a 10 by 12, but everything else will be done on a 14 by 17. Okay. Because we are dealing with thick anatomy this time, right? Femur, hips, pelvis. We are going to be using the grid. We are going to be using the table bucky. Okay. So pretty much almost everything, exception being the Danielius Miller, will be done here inside the table bucky. As always, anytime you're working the table bucky, make sure to turn on your detent, and then make sure to lock yourself in laterally. Wherever that is. Good. You do not need to lock yourself in longitudinally, right? Because instead you're going to take the tube and just line it up to your bucky once you're ready. Okay. So, who would like to be our first volunteer?
I'll do it.
All right, Amy, come on over. Now, on this one, for if you have an actual patient, you do want them to take off their pants, okay, and potentially their underwear as well, okay, because it may cause artifacts. So make sure you just gown them and then have them remove everything from the waist down. Now they don't necessarily need to take their shoes off for this exam, but if they're taking off their pants anyway, they're probably going to have to take off their shoes. Okay, but we're just going to demonstrate this on a fully clothed patient. So if you would just have a seat, please, and then lay down, head over there by the pillow, face up. So very similar to when we were doing our abdomens, we do want to make sure that our anatomy is straight on the table. Right? In this case, it is going to be the femurs. So whichever femur you're interested in, make sure that it's straight, make sure it's not coming off at some weird angle, right? If it is, go ahead and adjust that before you start positioning. Let me put on some gloves as well. Put them up. Thank you. Thank you. Okay, so anytime you're here on the bucky, we're going to be at a 40-inch SID, right? Just make sure that it locks in and it gives you a green light. If you don't have the green light, double check everything, double check your locks laterally, double check your locks, vertically, and then double check to make sure your detent is on. I'm going to go ahead and line up our tube with the bucky here. And then, let's see, turn off these lights. Okay, so first off is going to be which one? AP distal. Okay, so if you take a look at the notes, you'll notice that when we do these, there is going to be some rotation of the leg. And the amount of rotation will depend on whether you're doing the distal or the proximal part of the femur. Okay? When you're down by the distal, you're trying to get what looks like an AP knee. Right? If you remember on the AP knee, we wanted to try and internally rotate the leg a little bit, about 3 to 5 degrees, at those epicondyles parallel to the IR. We're doing the same thing here with the distal femur. When we get up here to the proximal femur, then we're going to be looking for what looks more like an AP hip. In order to get an AP hip, you will need to internally rotate the leg about 15 to 20 degrees. Okay? So there's a bigger rotation of the legs when you're doing proximal compared to distal. Okay. When we're doing distal, our goal is just to get our collimation here, the bottom of our cassette, about 2 inches below the knee joint. Okay. So the leg is going to be long. You are going to need 2 shots on pretty much every single patient. So for our centering, right, there's not going to be an exact centering point. All we're going to do is we're going to look for that knee joint. Right? So here's that apex of the patella. Right? Half an inch below is that knee joint. And we are going to go about 2 inches distal to this. Okay, so I've got my 3 fingers, which is 2 inches for me. All right, so 2 inches distal, and then mid leg, and then I'm just going to make sure there's a slight internal rotation. Okay, does that make sense? Okay, once you're there, then we can just mark and collimate. Okay, so my marker will let go of this. So we're going to mark laterally again, femurs thicker proximally than distally, so you're going to have more room for your marker on this distal end. And then just collimate in. Okay. Make sure that you have light on both sides of the legs, 2 inches below that knee joint, straight down the middle of the leg, about 5 degrees in terms of rotation. Okay, does that make sense? Pretty straightforward? Yes, okay. Okay, so for the proximal femur, okay, this time we are going to be centering right here by the femoral neck. Okay, so in order to locate the femoral neck, we have several tricks. Okay, the official way that you will see in Bontrager is you are going to go to the patient here and you're going to palpate for the as-is. So, okay, we have the as-is right here. From this as-is, you will go 1 to 2 inches medially and then 2 to 4 inches distally. Okay, so we're going to go about 2 inches, sorry, we're going to go about 2 inches medial and about 4 inches distal. So I've got my as-is, so 3 fingers, 2 inches medially. And then I'm going to take my fingers here and then go 4 inches distally. Okay. Or ideally I would just do 2 of these. Okay, so 2 inches medial, 4 inches distal. And I'm at this point right here. This should be where the femoral neck is. Okay. Now, something interesting. The femoral neck is also usually located at the crease that forms when the patient bends their leg. So, Amy, if you just bend your leg slightly, perfect. You see how we're right there as well? Right on that crease, okay? You can straighten back out. So you don't need the patient to bend their leg too much, just a slight bend so you can find that crease. That's another way to approximate the location of the femoral neck without having to go to the trouble of measuring it out. Okay? So either find it as is, 2 inches medial, 4 inches distal, or just ask the patient to bend their leg slightly. Perfect. Right? You can see that crease there, and you go right there in the middle of the crease. Okay?
In the job cancel, does it in intertropical clip, right?
I don't think so.
Right, so bend just slightly in.
You can
Perfect.
access it.
All right, so there's the crease. Right. Okay, so this should be at the level of that femoral neck. All right, relax. And now this time, right, we are going to take this leg and internally rotate how much?
15 to 20.
Good, 15 to 20. Good. But almost like you're doing a Mortise, right? Mortise is the same rotation. So basically, you have an ankle Mortise down here, and then you're going to have your AP femur proximal up here. Okay. Another thing to note, your AP proximal femur is pretty much the same as your AP hip. If you take a look at your notes, right? Take a look at the positioning for an AP femur. Take a look at the positioning for the AP unilateral hip. What's the difference?
Both legs are
What is that?
internally rotated in between.
Okay, for the bilateral, yes. What about for the unilateral hip?
What's your name?
So, what's the difference between your AP proximal femur and your AP hip unilateral?
Flex the leg 90 degrees.
Hmm? If you take a look,
In the vertical?
it's the same thing. Right? It's literally the same thing. I just copy pasted from AP proximal femur to AP hip. So, okay, you can relax it like Amy. The main difference then is that your cassette size. Right? With the AP hip, you're going to be using your 10 by 12. With the femur, you're using your 14 by 17. Okay? All right, let's see. Okay, I think that's good for now. All right, Amy, come on off.
I'm really getting comfortable with
Would anyone else like to come over here and get comfortable?
I will.
Okay. So this time, we're going to be doing the lateral femur. Okay, now with the lateral femur, just like with the lateral lower extremities, we are going to be rolling the patient towards the affected side, right? So if it's the left leg of interest, we will roll them towards the left. Okay, so Karen, if you turn over to your side, please. Good. All right, now, let's see, I'm going to start with this lateral distal. All right, so lateral distal is going to be very similar to the other lateral lower extremities you've done. So the leg that we don't care about, we're going to put that. The leg we do care about, we're going to have slightly bent here in the middle. Okay, and then we're going to make sure that the lower part here is in a true lateral, right? So we want the interepicondral line perpendicular to the IR. We want this patellofemoral joint perpendicular to the IR. We want the patella perpendicular to the IR. Once again, just like with the AP distal femur, there is no one centering point. Once again, our goal is going to be to find that knee joint, right? 1 inch distal to that epicondyle. And now we're going to go another 2 inches distal to this. And we're going to put the bottom of our light right there. Okay. So bottom of the light is 2 inches distal to the knee joint. Okay? And then we're going to take our central ray, and we want to put our central ray here into the middle of the legs. So there's several ways we can do this, right? So we can put it right here, keep the tube head lined up to our IR, or we can even turn it to match the anatomy. If you turn it to match the anatomy, you will have a much easier time collimating, right? Otherwise, if you leave it straight, you can collimate, but you'll end up with more light around the sides. Okay? The way you do it will depend on where you are. Some places will let you turn the tube head, some places want to keep it straight. If you do keep it straight, you have a lot of light in the corners, so those are great places to put your markers. If you do turn your tube head, at that point, it's thicker proximally than it is distally, so you will have more room on the distal end now to put your markers. Okay, so it's just all about where you have more room for your marker, where you have more white space. Here you probably want to turn the patient a little bit more. Good, get a nice lateral here for that distal portion of the femur. Now, when we get to the proximal portion of the femur, then things are going to be slightly different. Let's see, so first of all, our rotation is going to need to change. Careful, sliding towards you. If you take a look at the way this hip is positioned right now in the femur, right? The femoral head, femoral neck are going to be right here. Okay? We do not want the patient in a true lateral. Turn your hips all the way, right? Because this is going to superimpose the femoral heads. So you get the patient lateral, and then you'll turn them back about 15 degrees, right? So kind of like how we had the patient before. This way, you don't have that overlap between your two femur, right? But you keep that femur nice and close, no OID. Okay, we're going to find the pelvic, the iliac crests, right? And then we're just going to put the top of the light right where those crests are. So here's the level of the crests. I'm going to go ahead, put the top of the light field there, and then just center in our anatomy. Okay? Once again, if you want, you can go ahead and you can turn your tube head to follow the anatomy. Okay? Whichever way you do it, make sure you collimate, and then make sure you place a marker. Okay, so anywhere that you have good light, you don't want to put it in the area where it's thickest, right? Put it somewhere where the anatomy is thin and you have more room, more light.
And then you would shield the other side of the patient?
Okay, yes, good question. How do you shield on an exam like this?
Isn't it? Oh, sorry.
Well, yes, what do you
Oh,
think?
for women, isn't it like optional? And for men?
I thought that was for the pelvis.
Okay, so for the pelvis, which we're about to get to, the pelvis is going to be very similar to the abdomen. Right? When we were doing the abdomen, you could shield males, but you couldn't really shield females. Because abdomen, pelvis, they're both bilateral. You're getting both sides at once. Exams like these, they are unilateral. You're only going to see one side at a time. Oops. So you can shield the other side. However, you want to make sure that you do shield without covering any of the anatomy you care about. Right? So you don't want to go past the midline. Oops. Right? Because over here, you've got femoral head, we have femoral neck. We don't want to accidentally cover that with the shield. Okay? So we know that should be on the left half of her body. So we can put the shield over the right half of the body, but we don't want to bring the shield so far over that it covers the left half, it covers that femoral head, femoral neck. If we were doing the distal, now our light field is really far down. We can go ahead and bring this to cover the rest of the patient. Okay? Because now this isn't going to be in your way. It's not in your light field, it's not in your anatomy. So for all of your distals, you can fully shield your patient. For all of your proximals, you will need to half shield your patient. Shield the half that you are not interested in. But make sure you do not cover the side that you are interested in. All right, thank you, Sharon. Let me move this out of your way first. Okay.
What position was this one?
So those were the femurs. Sharon, we did the distal and proximal laterals. So the first one was the distal, the second one was the proximal. Let's see, what do we have next? Pelvis. All right, Daniel. Have a seat, please. Lay down on your back, face up. Now the pelvis is very similar to the abdomen in that we want to make sure that the patient is straight before we do any positioning. With the femur, we have some wiggle room, we can move the leg back and forth, right? But when we're doing the pelvis, when it's the whole patient, you definitely want to make sure the patient is straight. So come to the foot of the bed or go to the head of the bed, right? Make sure that the patient looks straight. If they don't, a lot of times you can take the sheet, right? And then you can kind of like wiggle them back and forth, okay, until they do look straight, okay? If you need to, you can also grab the sides of the sheet and pull them over towards you. The biggest issue with that is when you do that, you risk rotating the patient as well. Okay, so be careful doing that. Make sure you don't accidentally add rotation where you don't intend to.